Good morning. I'm presenting a case, a 62-year-old postmenopausal lady, housewife by occupation from Nashik, belonging to middle socioeconomic status. She is graduated, presented with a chief complaint of bleeding per vagina since 3 months. Patient was apparently well 3 months back. Since then, she noticed bleeding per vagina, which was insidious in onset. Initially, it was scanty in amount, initiating with staining of undergarments, which progressed to soiling of undergarments, requiring changing for 2 to 3 times a day. No history of passage of fresh tissues or cloths. No history of foul-smelling discharge. There is no aggravating or relieving factors. There is no history of similar complaints in past. No history of mass per vagina that she complains of. No history of high-risk sexual behavior in self or partner. No history suggestive of low backache, white discharge per vagina, fever. There is no history of pedal edema, pain over calf region. No history of urinary disturbances. No history of bowel disturbances, pain over thigh, or loss of weight or loss of appetite. There is no history of chronic pelvic pain or pain abdomen. There is no history of yellowish discoloration of sclera or skin. There is no history of shortness of breath, hemoptysis, or loss of consciousness, bony pain. And there is no history of multiple sexual contact with multiple sexual partners or HPV-related illness in husband. She is not a known case of diabetes mellitus, hypertension, or asthma. She does not give any history of consumption of medications of long durations. There is no history of intrauterine copper device or drug abuse or any surgical interventions in past. No history of partners' warts in self or partner. She does not give any history of undergoing any pap smear. She attained menarche at 13 years. She got married at 17 years. She is P4, L4, all full-time normal vaginal delivery. Age at first childbirth was 19 years. She attained menopause at 48 years of age. That is 14 years back. No similar history. No history of similar complaints in first or second degree relative. She consumes mixed diet. Her sleep is sound. Appetite is normal. Bowel and bladder movements are normal and regular. To summarize, 62-year-old lady belonging to middle socioeconomic status with no high-risk sexual behavior, presented with bleeding per vagina since 3 months, which is insidious in onset, with progress from scanty at the beginning to requiring change of undergarments 2 to 3 times a day. There is no associated symptoms.
Okay, go back to your history. First slide. Yeah. Okay. So when you're presenting this patient, you know she's already postmenopausal. Okay. So whenever you're presenting a gynae case, you need to clarify what type of bleeding this is. So you need to, in the chief complaints itself, you need to say that this is a 62-year-old lady who presented with postmenopausal bleeding for the past 3 months. You need to specify that. Okay. So I know it is, when you tell the whole history, it is... okay, it is assumed that it is postmenopausal bleeding, but this should be mentioned. Okay.
Sure.
So you present it as postmenopausal bleeding for the past 3 months. Okay. This is okay. Serious in onset, initially scanty and then increasing. No history of passage of, don't say any fresh tissue, no passage of clots or any, and no foul smelling discharge. Okay. No aggravating or relieving factors. This is all right. Okay. Second slide.
Let's repeat it.
Yeah. So, no history. Okay. So, no similar, again, you've repeated that. No history of similar complaints in past. So, instead of saying that, you need to tell what her perimenopause was. Okay. So, perimenopause is the, what is menopause, by the way? What is the definition of menopause?
Menopause is complete cessation of menses for at least 12 years. Which
not 12 years, 12 months, bache. 12 months.
12 months. Yeah. Sorry.
Yeah.
Months.
Okay. So perimenopause is the period preceding the menopause, wherein the cycles may become irregular. The patients may have scanty or heavy periods coming at long intervals. So this period may last for 1 year. It may last for 3 years. It may, for some women, it may even last for 5 years. So when you are saying no history of similar complaints in the past, don't say that. You can say this was the first episode of postmenopausal bleeding. She did not have any such complaints anytime since her menopause. Her perimenopausal period was uneventful, or if it was eventful, then you can say that she had heavy periods during her menopause, during the perimenopause, she was passing clots, whatever the history was. So say no previous complaint of postmenopausal bleeding anytime since the 10 years she's had menopause, and the perimenopausal period was uneventful. Then don't say no history of mass per vaginum. Just say no history of, she has not noticed any lump or mass in the external genitalia. Patient is unlikely to report with a mass per vagina unless patient is, feeling it by herself with her finger. So normally a patient reports when the patient has some visible lesion. So just say no history of any lesion or mass in the external genitalia. Okay. No history of high-risk sexual behavior in self or partner should come later. Okay, here you are first telling the presenting complaint. First should be your presenting complaint, then should be your associated complaints, then should be your negative history, and any history of high-risk sexual behavior should come in the personal history. Okay.
Sure.
So this is okay. Then again, don't say no history suggestive of PID. You can just say no history of any low backache, any foul smelling discharge per vaginum in the past. Go to your next slide. Yeah, so no history of pain over thigh, back. No history of swelling in the legs. Instead of saying pedal edema, say swelling over the legs. This is okay. No history of any urinary or bowel disturbance. No history of loss of weight, pain, abdomen, yellowish discoloration, shortness of breath. Headache, seizure, LOC, please avoid. Primary onset with brain mets is very uncommon in cervix. So unless the patient is telling you, don't say it. Okay, no history of bony pain is okay. All right. So, yeah, next slide. So past history, no history of diabetes, no history of medications of long durations. So HRT is not so important in a case of Ca cervix. Just say no history of any prolonged medication, no history of any comorbidities like diabetes, hypertension, asthma, and no history of any immunosuppressive disease. No surgical intervention. Personal history, then you come, no history of any high-risk sexual behavior or promiscuity in either self or partner. No history of any genital disease or warts in the self or partner, and no history of pap smear. No history of pap smear is important, so it is good that you have taken it. Okay. Then menstrual history is okay. Why is menstrual history important?
Ma'am, it has been found that early menarche or increase in the number of it is associated with increased sexual contacts, is associated with increased risk of cervical cancer.
Okay, so in the personal history, you should also be asking history of smoking, okay, because that is also a high risk factor, and you should be asking any history of, rather than IUCD, you should be asking no history of any oral contraceptive use or any other contraceptive use, okay, because IUCD per se is not directly linked to cervical cancer, but there are reports of long-standing use of OCPs and adenocarcinomas of cervix. So now that we are here, what are the risk factors for cervical cancer? Just tell me.
One of the most common implicated risk factors for cervical cancer is human papilloma infection with human papilloma virus, and along with that, it is associated with increased risk in those who smoke, as well as the, it is majority. It is also it is seen in patients who consumes OCPs for very long duration, especially the adenocarcinoma variant.
So Yogesh, I can hear your papers rustling. Try not to read from your paper because you will not have your papers there. Okay. Secondly, go with the important risk factors first. So cervical cancer is due to the persistent HPV infection. Okay. So you have to say this word, persistent HPV infection, because HPV infection is present in almost 98 to 99% of sexually active adults, but more than 95 to 98% of it is cleared by our immunity. It is only in patients who have persistent HPV infection that some percentage of those persistent HPV infections lead to the development of cervical pre-invasive lesions and then to cervical cancer. Along with this, there are certain other risk factors which increase the risk of cervical cancer, namely early coitarchy, multiple pregnancies, multiple sexual partners, poor genital hygiene, immunosuppressive diseases, especially HIV, smoking, and last may you can say long-term oral contraceptive use. Okay, so why does smoking lead to increased chances of cervical cancer?
Ma'am, it has been implicated that smoking is associated with increased DNA adduct formation of DNA adducts, which will impair the DNA repair, and thus it is associated with increased risk of transformation of malignancy.
More than that, in cases of cervical cancer, basically smoking impairs the functioning of Langerhans cells. Okay, so does HIV infection. So all these, when the Langerhans cells are impaired, they cannot clear off the HPV infection. So the main underlying cause is persistent HPV infection. So all these risk factors are more or less leading to either increased chances of HPV infection or decreased chances of repair of those HPV infections. So if you have multiple sexual partners, more likely to have genital abrasions, more likely to have vaginal and cervical abrasions, and more likely to have HPV infection. Similarly, what we did not mention, genital diseases like herpes. So all these, they are basically causing trauma, genital trauma, and as a result leading to increased chances of HPV infection. Immunosuppression, smoking, all these factors are leading to decreased clearance. Okay, so these are basically the risk factors. And protective factor is obviously when you are getting yourself screened properly, and to an extent HPV vaccination, which we will talk about. Okay, go ahead. You don't have to say sleep sound, appetite normal bowel, bladder and sleep habits. That is okay. Summary should be 62-year-old lady. Don't say no high risk sexual behavior. Okay, unless she has it, don't say. So 62-year-old lady presenting with postmenopausal bleeding for the past 3 months, which is insidious in onset and now increased to change of undergarments for 2 to 3 times a day. Okay. What you did not mention in your associated symptoms, if this was a younger female, let us say she was a 48-year-old lady who was perimenopausal, okay, who had not attained menopause, then you should, besides, so she may have presented with irregular bleeding. So you have to clarify what type of bleeding it is, whether she's having repeated the menses, whether she's having intermenstrual bleeding or whether she's having postcoital bleeding. Even in a postmenopausal woman, you should ask history of postcoital bleeding. That should be there in your associated symptoms or your negative history. So do ask history of postcoital bleeding. Okay? Sure. Yeah, I think that is enough. Yeah, okay, go to your examination.
General physical examination, 62-year-old educated lady, well oriented to time, place and person, moderately built and nourished, BMI 22.2 kilogram per meter square, ECOG 1, her vitals are stable, she is afebrile, there is no pallor, icterus, clubbing, cyanosis or generalized lymphadenopathy or pedal edema, no supraclavicular lymph node enlargement. Patient was examined after informed consent in presence of female chaperone and in supine lithotomy position after emptying bladder.
Okay, so you want to see her in a lithotomy position or in a dorsal position? Are you, do you normally get lithotomy stirrups in your examination table?
No, ma'am.
So say it's in a dorsal position. Most of the times we see it in a dorsal position, right? Because we don't have lithotomy stirrups. Lithotomy will be wide open, okay? Most of the times we just ask the patient to flex, empty the bladder, okay? So you should be writing that, emptying the bladder. I know it's this thing, but here it is important where you're doing a pelvic examination. Ask her to empty the bladder, stand on the right side, okay? And in a dorsal position. Lithotomy position is generally not, we don't do it in the OPD, okay? So dorsal position, okay, yeah. Oh, sorry, you've written after emptying bladder. I'm sorry, yeah. Okay, so again, the same thing, systemic examination, yeah, should come per abdomen examination. Yeah, okay, so fine. This is all right. Just go to your per abdomen and this thing, yeah.
Genital examination, vulva appears normal on inspection with normal urethral orifices, no evidence of discharge or bleeding, no evidence of scar, sinus or prolapse. Per speculum examination, solitary.
Per abdomen, you should mention your per abdomen findings before this. Okay. We are assuming it is soft, no abnormality. Okay. Per speculum, yeah. No, so per abdomen should come before per speculum. You will not do. So please mention in the order in which you see the patient. First you do a general physical examination, then you do a systemic examination, including breast examination. Please do not miss breast examination, especially in a female patient.
Sure, ma'am.
Okay? Then you come to per abdomen, then per speculum, PV and PVR. Okay? So per abdomen should come before this. So go to your per speculum.
Sure.
Let's just cover the salient features. Yeah.
A solitary ulcero-infiltrative growth about 3.5 cross 2.5 centimeter present over the anterior lip of cervix, extending to the upper part of the vagina into the posterior lip of cervix. Irregular margins and floor is covered with the necrotic materials and it bleeds on touch. No evidence of any other lesions in the vagina.
Okay. Yeah. Okay. Next.
Per vaginal examination, per speculum findings were confirmed. It is non-tender, no local rise in temperature, irregular ulcero-infiltrative growth about 3.5 cross 2.5 centimeter, hard to firm in consistency, left lateral, and anterior fornix is effaced. No evidence of any adnexal lesions. On rectovaginal examination, bilateral parameter appears normal and rectovaginal septum appears normal. Rectal mucosa is normal. Per abdomen,
That's okay. So per vaginal examination, you don't need to mention per speculum finding is confirmed. Okay. And please don't write non-tender, no local rise in temperature until unless you're finding something. Okay. So this is okay. Irregular ulcero-infiltrative growth about 3 into 2.5 centimeter, firm to hard, involving the anterior lip of cervix. So you have to say anterior lip of cervix with the effacement of left lateral and anterior vaginal fornix. Then you have to say rest of the vaginal walls are normal because you are trying to clinically stage the disease. So you should be mentioning everything. So you have to say rest of the vaginal walls are free. Okay. Fornices are free. Don't say no history of any adnexal lesion. Okay. You have to mention when you're doing a per vaginal, how do you assess for adnexa? You basically see the fornices. So just say all the fornices are free. On rectovaginal, so you want to do a rectovaginal exam. So how do you assess the parametria? Do you do it by a PR examination? Do you do it by a PR examination? How do you assess the parametria?
Ma'am, there are two methods to examine the parameter, but most commonly followed method is bidigital examination, in which one index finger will be in per vagina, index finger will be in the vagina, and the middle finger will be in the rectum. And we try to follow the lateral pelvic wall, look for any induration, any nodularity, or any irregularity.
Okay. Yes. Second, what is the second method? You said there are two methods.
Yeah, ma'am. Bidigital.
Okay. So what you need to mention in your exam is, yes, you do a PVR examination. Either you can keep one finger in the vagina and one finger in the rectum, or you can keep use one hand and keep one finger in the vagina and one finger in the rectum. You go up, you start from the cervix. Just roll your fingers from the cervix, move laterally up to the lateral pelvic wall and assess for any nodularity, any thickening or any induration. And you need to go higher also. You know, it is not just that you are just assessing the parametria, you are just assessing the lower parametria. You need to push your fingers higher up so that you can assess the upper parametria as well. An easier way to do it, and that would be useful in your clinical practice, is to do a bimanual examination using your finger in the rectum. Okay, so this we found was more easy when we did it in our residency years in Tata. So basically, we put one finger in the rectum, we put one hand over the abdomen, and then we assess the parameter. You may find this is clinically better in your practice, but in your exam, just mention PVR, what you have mentioned to me previously. You can either use one hand or you can use two hands. Okay? Fine.
Okay.
This is okay. Yeah. Go to your next slide.
To summarize, 62-year-old lady with ECOG1, no comorbidities, presented with bleeding per vagina, a postmenopausal bleeding since 3 months, which is insidious in onset with no aggravating or relieving factors. On examination, there is 3.5 cross 2.5 centimeter lesion involving the anterior lip of cervix, extending to the upper third of the vagina. Left lateral polyps not free. Ca cervix. My probable diagnosis is Ca cervix stage 2A1.
Okay, so don't mention extending to upper 1/3 of the vagina. So,
Sure.
You don't have to mention the stage here. Okay, so upper 1/3 of the vagina can also mean that, the lesion is involving the upper 1/3 of the vagina completely. This is just effacing the cervix, effacing the fornix, because this will have a clinical implication of on your management. Okay, so a 62-year-old postmenopausal lady who has a 3 into 2 centimeter growth, which is involving the complete upper one-third of the vagina, that is also 2A1. Similarly, the same 3 into 2.5 centimeter disease, which is just involving the vaginal fornices, that is also 2A1. Okay, but your management of these two clinical scenarios will be different. Okay, why? Because if you are contemplating surgery, you need to have at least a 2 centimeter margin. That is easier to achieve. Okay, I'm giving you a hint of what is to be done also, but in any case, if you do a surgery, if you're contemplating surgery, a lady who just has involvement of the vaginal fornices, you can achieve a 2 centimeter margin. Okay. In a lady where the complete upper one-third is involved and you need to sort of do almost a subtotal vaginectomy in a 62-year-old to achieve a disease-free margin, such cases you would not like to consider for surgery, especially when a lady is postmenopausal. Okay. So here when you know it is just involving the vaginal fornices and you are bending towards surgery, let us say, don't mention this extending to upper third of the vagina. Okay, just say 3 into 2 centimeter lesion involving the tip of cervix and abutting the left fornix of the vagina. Rest of the vaginal walls are free. Do mention that because it will help you in justifying what approach you will take to manage this patient. Okay? Okay. Next slide. Okay, is this over?
Yeah.
Okay, so yeah. How will you proceed to manage this patient?
I'd first like to confirm my diagnosis. And I'd like to confirm my diagnosis. Before that, I'd like to do routine blood investigations. And for confirmation of diagnosis, I'd like to take a biopsy from the growth. And based upon that, I'll further stage the disease based upon the biopsy reports.
Okay, so what investigations will you do and how will you do a cervical biopsy?
After informed consent, I explain the procedure before any procedure.
That's okay. That's understood. Just tell the relevant points.
Okay.
How will you do a cervical biopsy? Will you take her into the OT? Will you do it in the OPD? What instrument will you use?
We usually take a patient in minor OT, in lithotomy position, and after a per speculum examination with the help of punch biopsy forceps, we take tissue from the most representative area.
Okay, so this can be done in an OPD. You don't need to do it in a minor OT, and in many cases, it may not require a lithotomy position as well. And you're right, you use a Keyes punch biopsy forceps. And which part of the growth do you take the biopsy from?
Most representative area, that is periphery of the growth.
Why do you need to take it from the periphery of the growth and not from the center?
Ma'am, tissues from the center may represent the necrotic material that will have a high false negative rate, ma'am. Second
reason, when you take the biopsy from the periphery of the growth, you can also comment on the invasion. If you only take the necrotic material from inside, it may or may not show, number one. Number two, it may show cancerous cells, but it cannot comment on stromal invasion. Okay, so that is why we take the biopsy from the edge of the lesion or the periphery of the lesion, so that we take a small amount of normal tissue due to which the pathologist can comment on the stromal invasion. Okay, so that is important to show that it is an invasion. Okay, so you've seen the patient in the OPD and you have taken a cervical biopsy. So what investigations would you do further? Besides the investigation, how else would you assess the disease?
As it is more probably a cervical cancer, I'd like to locally stage the disease with MRI pelvis with contrast, and based upon the further reports, I'd like to further stage the disease.
Now, it is cervical cancer. So, you've done an MRI pelvis with contrast. What else? Chest X-ray. Would you not like to assess the upper abdomen? If you just do the pelvis, You will miss out the paraortic lymph nodes.
Paraortic
You will
lymph
miss out the upper abdomen. So how will you do that?
Either MRI abdomen and pelvis or
Correct. That's the
complemented.
answer. Right. So in a patient where you are already suspecting Ca cervix clinically, and most likely she is to be a Ca cervix, it does not look advanced. Okay. Clinically, this does not look advanced. At most, it is stage 2A1. Okay. And less than 4 centimeter disease. So you would like to do an MRI of the whole abdomen and pelvis with contrast along with the chest X-ray. Okay. So why an MRI? Why not a CT?
Ma'am, for MRI has been found to be better for soft tissue delineation, especially in this case where there is a possibility to rule out parametrial invasions which will change the management aspects. Hence, MRI pelvis is preferred over the CT scan.
Okay, Yogesh, there is a lot of disturbance your end, so you need to minimize your disturbance, number one. Okay, so MRI pelvis is, yes, with contrast, it helps in soft tissue delineation. Besides that, it is more useful in assessing the tumor size. It is more accurate than finger assessment for the tumor size. Secondly, for the stromal invasion. And third, for the parameter involvement, and it is as sensitive as CT in assessing the lymph node status. So, the lymph node status, we specifically want to see the status of pelvic and paraortic lymph nodes and also rule out any upper abdominal metastasis. That is why MRI is preferred over a CT scan. Okay. What is the role of PET CT?
Ma'am, in PET CT can be preferred when there is suspicion of paraortic lymph nodes or pelvic lymph nodes.
How will you assess? No, so how will you know? So a patient comes to you clinically. She comes to you in the OPD. Okay. So how do you know that, okay, in this patient I should order an MRI or in this patient I should order a PET CT? You would not really like to do an MRI of the whole abdomen and pelvis with contrast, which is not only expensive but a long study, takes almost 45 minutes, and then again order a PET CT. So is there any way you can decide or triage which patients to go, send for an MRI of the whole abdomen and pelvis and which patients to consider for a PET CT?
Sorry, ma'am, I don't know.
Okay, so basically if a disease is locally advanced, okay, if a disease is locally advanced, then in those cases, see, the paraortic lymph node involvement obviously increases once the stage starts increasing. So if in stage 2 it is about 20%, in stage 3 it increases to 30 to 40%, okay. So in a locally advanced disease, so it is 2B and onwards, okay, 2A2, 2B and onwards. Here in these cases, it is preferable to do a PET CT. According to the universal guidelines, an MRI pelvis with contrast is still preferred for these patients because it helps in basically knowing whether the adjacent organs are involved. So if it is a locally advanced disease, many times it may involve the base of the bladder, it may involve the rectum. So MRI will be useful in telling what is the local involvement of the organs, and PET CT will help us in telling what distant metastases there are. So in a locally advanced cervical cancer disease, if the patient is affording and you have the facilities, then in those cases we normally advise an MRI of the pelvis, only the pelvis with contrast along with the PET CT. MRI pelvis will tell about the local tumor factors and its involvement with the adjacent organs, while PET CT will tell us about any distant mets, especially the paraortic and supradiaphragmatic disease. Okay. So, what is the role of EUA? Should you do an examination under anesthesia for all patients?
It's preferable, ma'am.
So, as a clinical practice, do you do EUA for all patients of cervical cancer who come to your OPD? No, you do not. Okay.
Not really.
You do not. So, only in patients where your clinical findings are indeterminate or there is some amount of thickening, because in India, pelvic inflammatory disease is very common. So, many times we find that the parametria is thickened or indurated, which can be because of the pelvic inflammatory disease rather than due to the disease. So in such cases, no, we give a course of antibiotics and then do an EUA. So A, when your clinical findings in a OPD are indeterminate and you have to decide between either surgery or radiation therapy, number one, or number two, where there is high amount of induration of parameter due to pelvic inflammatory disease, which is precluding your normal pelvic examination, okay, then in those cases you give a course of antibiotics and anti-inflammatory drugs and then do an EUA. Or thirdly, if it is too painful for the patient and patient is not allowed, then in those rare cases you do an EUA, okay, not always. Is it always mandatory to do a cystoscopy and a sigmoidoscopy?
Not really, ma'am.
So in which cases should you do?
In those patients who complains of
okay, let me ask this question. In which cases should you do a cystoscopy in cervical cancer?
In those patients who presents with urinary disturbances like increase in frequency or urgency or hematuria.
Okay, but just the presence of those symptoms can be because of a UTI also. Are you going to base your decision just on the basis of your history? So a lot of patients can present with urinary disturbances because UTI is very common in these patients. You have to assess the patient clinically, okay, if the disease is locally advanced and involving the anterior vagina especially, okay. Clinically, if the patient is involving the anterior vagina, it is likely that the base of the bladder may be involved in some cases. Secondly, if your MRI findings are suggestive, if it is a locally advanced cancer and you have effacement of bladder wall with the cervical growth, in those cases you have to do a cystoscopy. Why do you need to do a cystoscopy in these cases? Say it was a case of stage 3B, there was a large growth involving the cervix and upper two-thirds of the vagina, upper two-thirds of the anterior vaginal wall or posterior vaginal wall was involved. And MRI is saying that, there is loss of fat planes with the bladder and the cervical growth. Why do you need to do a cystoscopy when MRI is you already have an MRI, you have a clinical finding? Why do you need a cystoscopy? Will it change your management?
Ma'am, in case of just mere the bladder invasion has to be confirmed with histopathological diagnosis.
Yeah. So how will bladder invasion change your management? That's my question.
It will be locally advanced disease with stage 4A.
What stage will it be when it involves the bladder mucosa?
Stage 4A, ma'am.
Correct. So, what is the treatment for stage 3B and what is the treatment for stage 4A where bladder mucosa is involved?
Ma'am, in case of stage 3B, which is invasion of the parametria, the treatment of choice is radical CTRT. In those cases with bladder invasion, exenteration can be planned, ma'am.
No. Please don't put your foot in the mouth. Don't make such statements, okay? Exenteration is only for a very few subset of patients who have only a central stage 4A disease with no parameter involvement and with no distant myths. Otherwise, most of these patients present with parametral disease extending up to the pelvic wall and may or may not present with distant myths, okay? Treatment for stage 3B, rightly you said, is chemoradiation. In stage 4A, where bladder mucosa is involved, normally we start with systemic chemotherapy first. We give 2 to 3 cycles of systemic chemotherapy so that the disease retracts away from the bladder wall and then we give chemoradiation. If we directly give chemoradiation, there is a high chance of formation of fistula. Okay, even with chemotherapy, there is a chance of formation of fistula and that has to be explained to the patient. But between the two modalities, it is preferable to start chemotherapy first in stage 4A and then move on to chemoradiation rather than moving to radiation straight away. So that is why it makes a difference. Okay, so tell me what were the findings in your case?
In this case, we did an MRI for local staging, which was suggestive of there is around 4 cross 2 centimeter lesion involving the involving the anterior fornix, anterior cervical lip extending to the posterior cervical lip with effacement of fornices. Rest of the parametria is free. There is no pelvic lymphadenopathy, pelvic or para-aortic lymphadenopathy.
Okay. So how will you
And
proceed?
is well maintained. The planes with bladder and rectums are well maintained.
Okay. So how will you plan to, how will you manage this patient now?
Ma'am, I'd like to I'd like to first counsel the patient regarding the stage of the disease and disease factors, and I'd like to explain the treatment modality available, CTRT, radical CTRT versus surgical approach. I'd like to discuss in multidisciplinary board. Then I'd like to plan further treatment, ma'am.
Okay. So, this is a 4 centimeter growth in a 62-year-old postmenopausal lady, which is just involving the anterior vaginal fornices. So you have discussed in the tumor board. So what are the treatment options? What are the pros and cons of each treatment option? What will you tell the patient?
I'd like to explain the advantage and disadvantage of RT as well as surgery. With beginning with RT, I'd explain it is preferred for old age patients. The treatment duration may be long. I'd explain the procedures and complications associated with it, including the long-term complications like radiation proctitis, cystitis, dyspareunia,
Okay.
or sexual dysfunction.
So whenever you're giving your answers, and this applies generally to all questions in your surgical oncology as well, first you need to mention the efficacy, then you need to come to the side effects. Okay. Side effects come later. First the patient wants to know, patient is concerned. So most of the times in your clinical practice, you will come across patients who will say that, no, I want surgery, remove the tumor. Okay. So you have to tell them, first you need to mention that because this is stage, you have to, first of all, the stage is now stage 2A1. It is just 4 centimeters. So yeah, you said it is 4 centimeters or more than that on MRI?
4 centimeter. 4 centimeter.
Okay. So now the staging is no longer just clinical, but it is rather clinico-radiological. So what is stage 4A1? Is it 2A1 or 2A2?
Ma'am, I missed the call. Can you please repeat? Pardon.
A 4 centimeter growth, a 4 centimeter growth, is it 2A1 or 2A2?
2A1, ma'am.
Correct. So now tell me, so you have to tell the patient in a patient with a good performance status, you have to say 2A1, it is operable. Okay. So you have to say you have 2 treatment options. One is surgery, the other is radiation. First, you need to mention that both surgery and radiation, the efficacy rate, the survival rate is exactly similar, and that has been proved in multiple trials. Okay. So the efficacy rate of both are same. Number one. Number two, you need to say that with surgery, does she have any high risk factors on MRI? On the basis of MRI, can you assess what are the high risk factors which may require adjuvant radiation after surgery? One is the size.
High risk factor.
So one you have already mentioned is 4 centimeters on the
4
basis
centimeter.
of MRI. So this is just borderline. Finally, when you remove the specimen, if you do a surgery and you remove the specimen, the tumor size may be smaller or it may be larger as well. So I'm assuming we already have one intermediate risk factor here. Okay. LVSI is not possible to determine preoperatively. So what are the intermediate factors? One is the tumor size, second is the
tumor size,
and third is the LVSI. Okay. So LVSI, it is not possible to determine preoperatively unless you've done a cone biopsy. Okay. Normally, cone biopsy we don't do in all cases. We do it in selective cases, which we'll discuss later. So we only know on MRI. On MRI, we know that the size is 4 centimeters. One thing more which you can assess on a good MRI with contrast is cervical stromal invasion, whether it is less than 50% or more than 50%. If your radiologist is able to tell with enough confidence that the cervical stromal invasion is more than 50%, then these findings help us in decision making. Here we can tell the patient that, look, your tumor size is already 4 centimeter, which is one risk factor. The cervical stromal invasion, as reported in MRI, is more than 50%, which is another risk factor. Okay, so even if we do surgery, you will require radiation. And when we give radiation after surgery, the side effects are more because the uterus is not there, so the bowel comes and sits in that basin, and so the side effects of the process are more after surgery plus radiation. Okay, so That is how you need to convince the patient on the basis of clinical findings and on the basis of an MRI finding. Say this was on an MRI, this was 4 centimeter, but the patient, you cannot comment on cervical stromal invasion. There you have to tell the patient that you have two options. One is surgery, it is an operable disease. Second you have is a radiation. Okay, so you have to say that in this case there may be a 30 to 40% chance of adjuvant radiation depending upon what the risk factors are on the final histopathology specimen, and again explain that the radiation, with added radiation, the side effects are likely to be more. So in Ca cervix, you have to mention that we tend to avoid dual modality treatment. By that I mean, if you already know that there is a high risk that the patient will require adjuvant radiation, then in those cases it is preferable to send the patient to upfront chemoradiation straight away. So in this case, if the cervical stromal invasion was more than 50%, you would prefer to send her to chemoradiation. Okay. So let us consider a different scenario. Let us say it was a 40-year-old lady, sexually active, okay, with a 4 centimeter growth, again 2A1. Not possible on MRI to comment on cervical stromal invasion. Okay, she is concerned about her treatment options. Will your treatment options slightly vary in this patient?
Yes, ma'am. Surgery is preferred in younger age patients because.
So why is surgery preferred? What are the advantages of surgery?
Ma'am, surgery advantage is it is a shorter duration, or treatment duration is shorter, uh, and also based upon
Okay, I think this is
trials.
very long. I'll tell you the answers. Okay. So surgery, yes, you're right, it is a shorter procedure, but more importantly, it helps in staging of the disease and complete removal of the tumor, number one. Number two, in a young patient, it helps in maintaining the sexual function. Okay. Although the length of the vagina may be shortened by 2 to 3 centimeters, the pliability and lubrication is maintained, unlike radiation. Third, the ovaries can be preserved. So what is the incidence of ovarian mets in a squamous cell versus an adenocarcinoma?
In squamous cell, it is less than 1%, and in adenocarcinoma, it is less than 5%.
Yes, so it's about 2 to 3%. Correct. So ovarians in a young patient, ovaries can be preserved and can be transposed. So along with the IP ligament, they can be transposed high up along the parapole gutters, so that if in case patient requires adjuvant radiation, the ovaries can be saved from the radiation field and the patient can preserve the hormonal function. Fourthly, the complications, whatever the complications are there, are in the intraoperative and the immediate post-operative period. The long-term complications are lesser in surgery as compared to radiation. Whereas in radiation, you have side effects, you have acute side effects, but more importantly, you have chronic side effects, namely what? In this case, what is important?
Radiation
Vaginal
prophylaxis,
stenosis, yeah. Vaginal stenosis, dyspareunia, decreased lubrication, and obviously the rectal and the bladder functions as well. So in a young lady who is active and who has, who is concerned about her hormonal function, in such cases, surgery will be preferable not only to remove the disease, but also to transpose the ovaries, so that in case patient requires radiation later on, then in that case, the ovaries can be saved from the radiation field. So what is the percentage of squamous and adeno? How many cases, out of 100 cases, how many are squamous and how many are adeno?
Around 95% are squamous, 95 to 98% are squamous cell carcinoma.
No, you're talking about 70s. Nowadays, squamous is only 80%. Okay, adeno is almost 20 to 25%. How is adenocarcinoma different from squamous?
Ma'am, as per treatment wise, stage to stage, the treatment does not vary, but adenocarcinoma has been found to be associated with increased lymph node recurrences, increased rate of lymph node positivity, ma'am.
So adenocarcinoma, it is generally occurring in younger women, number one, and many such women, smoking is not associated with adenocarcinomas, unlike squamous carcinomas. Thirdly, HPV 18 is more common in adenocarcinomas, whereas HPV 16 is more common in squamous carcinomas. Adenocarcinomas have higher rate of hematogenous metastasis, and you are right. even with lymphatic metastasis with the same stage, adenocarcinomas tend to have higher recurrences rates as compared to squamous. But as of now, all our treatment guidelines for squamous as well as adenocarcinoma are exactly the same. So when you are deciding adjuvant RT or adjuvant chemo RT, then in that case, you will not take squamous versus adeno as a criteria in deciding whether a patient requires adjuvant radiation or chemoradiation. Okay. So can you tell me what are the types of radical hysterectomy?
Ma'am, radical hysterectomy is now we classify radical hysterectomy based upon the Perle-Moro classification.
No, there is another earlier classification. Most people are not
Piver,
using Perle-Moro, which is the commoner one.
a Piver-Ruclas classification.
Yes. So
Which
first
divides
tell me
into
the
type 1.
classification.
Type 1 is extrafacial hysterectomy. Type 2 is radical Verdun hysterectomy. Type 3 is
Type 2 is modified radical. Type 3 is radical.
modified radical.
So what do you do in type 2?
Type 2, in type 2, ma'am, ureter, the dissection, parametric dissection is carried out till the level of ureter, and also the anterior and uterosacral ligament midway, ma'am.
So ureter is always dissected, okay, whether you do a type 2 or a type 3, okay. So cardinal ligaments or the McInrod's ligaments and the uterosacral ligaments, they are transected midway to the pelvic wall and midway to the attachment to either the sacrum or the rectum, okay. And earlier, the older classification said that, in one case you remove upper 1/3, in another you use upper half. But as of now, we are not making this as a distinction. Even in type 2 or type 3, we are removing only upper 2 centimeters of vagina so as to achieve a tumor-free margin of 2 centimeters. Okay. So where do you ligate the uterine artery in type 2?
At the origin.
No, at the crossing of ureter. Okay. At the origin is type 3. In type 3, you transect the uterine artery at its origin from internal ilia and you take the McInrod's and the uterosacrals as laterally as possible close to the pelvic wall and sacrum respectively. Okay. And then, of course, type 4 and type 5 is type 4 you sacrifice the superior vesical artery in the upper 2/3 of the vagina, and type 5 is where you do a urethric reimplantation. That is more or less not used these days. So, okay. What type of incisions can you use to do a radical hysterectomy? First of all, more importantly, would you do it as an open procedure or as a laparoscopic/robotic procedure?
Ma'am, now open procedure is preferred over minimal invasive procedure based
Why?
on trial, LACC trial by Petro.
What did the LACC trial show?
It was a non-inferiority trial which showed that, which compared 4.5 year disease-free survival between minimal invasive as well as open procedures with over a period of 4.5 as a primary endpoint. It did not show any survival. It did not. The minimal invasive approach was associated with decreased disease-free survival when compared to open radical hysterectomy.
Correct. So the minimally invasive surgery was reported with more recurrences, both local as well as distant. It had more vaginal, more pelvic recurrences. It had a decreased disease-free survival as well as increased chances of death or decreased overall survival as compared to the open surgery. So what were the plausible reasons why minimal access had a worse survival? Why was that? What are the plausible reasons which are being attributed to inferior survival with minimally invasive surgery? In spite of removing the same amount of parametria, in spite of removing the same amount of vagina, why is minimally invasive associated with inferior survival outcomes? So basically, what has been attributed, the risk factors which have been attributed is we use a uterine manipulator many times in minimally invasive surgery for traction, okay. Secondly is that we are doing an intracorporeal colpotomy, okay. So we are basically cutting the vagina with the vaginal margin in a pneumoperitoneum. So presence of pneumoperitoneum as well as doing an intracorporeal colpotomy in a steep Fredlinburg position. Okay, so the patient is steep Fredlinburg. You're cutting the vagina inside a pneumoperitoneum. That may lead to potential seeding or carcinomatosis of microscopic cells, which can cause, recurrences. So these are the reasons which are considered as plausible reasons why minimal access has been having inferior survival outcomes. So now there are studies wherein they have shown that A, if you don't use a uterine manipulator, and B, if you don't do an intracorporeal colpotomy, you dissect the vagina from below, from the vaginal end, and close the vaginal margins. There they or do, in many cases, some doctors are doing a leap prior to doing a radical hysterectomy so as to remove the tumorous tissue and prevent the contamination of the operative field in a pneumoperitoneum. So they are, but these are in trial settings. As of now, to the examiners, you have to say that both NCCN as well as the SGO have recommended open surgery as the gold standard and have said that MIS is no longer advocated as the preferred modality because of the results of the LSCC trial. Okay, so the golden standard is open surgery as of now, and you have to mention the same during your exams. So what incisions can you use? Fast. One is, can you use any other?
Preferred is vertical midline incision, ma'am.
What else can you use? You're only confining yourself to the pelvis. Can you do a transverse incision?
Transverse incision not preferred, ma'am.
No, it is. It definitely is. Okay. So there is no indication that you only have to do a midline vertical. Okay. Unless you're suspecting something on PET-CT and you need to examine the upper abdomen. Okay. But even in a Maillard, I've given you the answer. So there are two incisions, Maillard and Cherny's. What are they? You need to know. Okay. Just read it up. Okay. In Cherny's, you detach the rectus from its fascia, and whereas in Maillard, it is a muscle cutting incision. Okay, so you can do radical hysterectomy with these two incisions as well. Once you proceed with a once you've opened the abdomen, what all things should you check before proceeding to radical hysterectomy? For the interest of time, I'll start giving you answers because it's already 10 o'clock. So when you open the abdomen, before you move to a radical hysterectomy, you should check the upper abdomen and you should check the para-aortic lymph node involvement, number one. Number two, you should open the spaces and check for parametria from the abdominal side as well. You have done a PV examination, and it is always a good practice when you take the patient to the OP, before you are making the incision, to do an EUA. Okay, do an examination under anesthesia before you pack the vagina. In radical hysterectomy, we normally need to pack the vagina with a ribbon or a vaginal pack. Okay, so after you do an EUA, open the abdomen, you check for any upper abdominal disease, you check for para-aortic lymph node involvement, you open the spaces and check the parametria from the abdominal side. Thirdly, you check for any involved suspicious pelvic lymph nodes. The reason for that is, if para-aortic or pelvic lymph nodes are positive, then in such cases, obviously the patient will require adjuvant chemoradiation. So in such cases, it is preferable to abandon the radical hysterectomy and send the patient for upfront chemoradiation. So as a protocol, every institute has a different protocol, but as a protocol in Tata, what we followed was, we would check all this. We would check the parametria. We would check the para-aortic basin. Lymph nodes, we would start with the pelvic lymph nodes first, do a complete pelvic lymph node dissection, send that for frozen. Okay, in case any lymph node turned out to be positive on frozen section, we would not do a radical hysterectomy. Reason being same, that it will delay the start on, if we proceed ahead with the radical hysterectomy, it will delay the onset of radiation, because radiation can then only be given after at least 4 to 6 weeks, number one. Number two, the side effects are much more, because the bowel comes and sits in the basin where uterus was. Okay, so the chances of radiation enteritis are much more, and all the radiation associated side effects. And upfront chemoradiation has equal survival rate as compared to doing a surgery and then giving radiation with lesser side effects. Okay. The fourth thing which you must see is basically push the bladder down, dissect the UV fold and start pushing the bladder down. Many times, especially in an endocervical growth, the bladder may be involved. The parametria may be free, the lymph nodes may be free, but the bladder may be involved. So these are 4 checkpoints which you should see. Open the abdomen, check for any distant meds and para-aortic, number 1. Check for parametria from the abdominal side. Check for any pelvic lymph node involvement and check for any involvement of bladder. Okay. After all these 4 things are clear, only then you should proceed with the radical hysterectomy. So you should know the boundaries of all the pelvic spaces, especially the paravesical and the pararectal space. So for the interest of time, Yogesh, can you quickly tell me what are the boundaries of paravesical and pararectal space?
Sorry, ma'am, I don't remember.
This is very important. You have to remember. This is a very basic question.
Sorry,
okay. So a paravesical space, the medial is a bladder along with the obliterated umbilical artery. Obliterated umbilical artery is a continuation of internal iliac. Laterally is obturator internus. Anteriorly is pubic symphysis and posteriorly is the cardinal ligament. In pararectal space, anteriorly is the cardinal ligament, posteriorly is the sacrum. Medially is the rectum and the ureter which is running along the uterosacrals, and laterally is the hypogastric or the internal iliac vessels. These are important because you need to open up these spaces when you proceed to do a radical hysterectomy. So they may ask you what are the steps of radical hysterectomy. First you start with the prerequisites, you develop the pelvic spaces, you dissect the ureter, take the uterine artery either at its origin or its crossing depending upon whether you're doing a type 2 or a type 3. Okay, dissect it down the ureteric tunnel. Then on the ureteric tunnel, you dissect the vesico-uterine ligament and free the ureter completely. Posteriorly, you dissect the uterosacrals close to its attachment to the rectum and transect it either close to the rectal wall or midway depending again upon type 3 or type 2. And then do a colpotomy taking a 2 to 3 centimeter margin. So you should know the steps of a radical hysterectomy. What is Querley-Morrow classification which you were talking about?
Querley-Morrow classification is it is based upon the embryological tissue basis. It classifies hysterectomy into type A, B, C, D, which is again type A is similar to extrafacial hysterectomy. Type B is further divided into B1 and B2. Type B1 is where you mobilize, you dissect till the level of ureter, but ureter.
So type B is same as type 2. We understood that. B1 is where you don't remove the paracervical lymph node. B2 is where you do remove the paracervical lymph node. Paracervical lymph node is a lymph node which is below the obturator nerve and medial to it. Normally, when we do a standard pelvic lymph node dissection template, we don't go below the obturator nerve. So paracervical node lies below the obturator nerve and lies medial to it. So B1 is where we don't remove and B2 is where we remove. Type C is similar to type 3 radical hysterectomy, but C1 is with nerve preservation and C2 is without nerve preservation. So can you tell me a bit about nerve sparing radical hysterectomy?
Nerve sparing.
If you don't know, you tell me so that I can proceed because there's a lot to discuss.
Nerve sparing is usually preservation of the hypogastric nerve, which is associated with increase. It has been seen that it is associated with improved sexual and autonomic functionality.
Right. Okay. So how do you do it?
At the level dissection, and anteriorly the dissection does not carry beyond the lower cervical veins because that would be associated if dissection is carried out below the.
That is just one of the levels, Yogesh. You need to be very systematic in your answers. Okay, you cannot just jump to the third step. You are telling me the third step first. Okay, so you're right. Nerve sparing radical hysterectomy is basically done because there are side effects associated with radical hysterectomy, namely the bladder, rectal and the sexual dysfunction. So in order to preserve these autonomic nerves, we do a nerve sparing radical hysterectomy. So basically the supply, the autonomic nerve supply comes from sympathetic and parasympathetic. Sympathetic comes from the hypogastric, superior hypogastric plexus which lies along the sacral promontory. From the superior hypogastric plexus, you have two hypogastric nerves running down. These hypogastric nerves then join the splanchnic nerves from S2, 3 and 4 to form the inferior hypogastric plexus. And then from inferior hypogastric plexus, both sympathetic and parasympathetic run to bladder, to vagina, to cervix, and to the rectum to supply autonomic nerve system. So superior hypogastric plexus is sympathetic. Inferior hypogastric plexus is a combination of sympathetic and parasympathetic, and splanchnic nerves, which come from S2, 3, and 4, they contain parasympathetic fibers. So when we do a type 2 or a type B radical hysterectomy, the nerves are automatically preserved. We don't need to preserve the nerves separately. So the concept of nerve sparing radical hysterectomy applies to type 3 radical hysterectomy, where you are dissecting close to the pelvic wall and the nerves are likely to be damaged. So the first step of nerve sparing radical hysterectomy is when we are dissecting the uterosacrals. So the hypogastric nerves, which carry the sympathetic fibers, they run between the uterosacrals and the ureter. So uterosacral is running like this, ureter is lateral to it. So in between these two, the space is called Okabayashi space. Okay, this Okabayashi space contains sympathetic nerve fibers in the form of hypogastric nerves. So these need to be dissected, they need to be lateralized, and then the uterosacrals is supposed to be transected in order to preserve these nerves. The second step comes when you are dissecting the parametria. So inferior hypogastric plexus lies on the dorsal aspect of the Matin rods, or the dorsal or the lateral parametria. So this needs to be preserved when we are dissecting and transecting the cardinal ligaments. So normally inferior hypogastric plexus is difficult to see with just gross eye. So many times we need to use loops to see this. The third step is when you are talking about the dissection of vesico-uterine ligament or the vesico-cervical ligament, that is the bladder pillar. Okay, so in these cases, the fibers which are coming from the inferior hypogastric plexus run along the posterior sheath of the vesico-cervical ligament. The bladder pillar, also called the vesico-cervical ligament, has two layers. One is the anterior layer, the other is the posterior layer. So, and the ureter is running in between these. So we need to dissect the ureter and lateralize it. Okay. So in order to dissect the ureteric tunnel, we will have to take the upper part or the anterior layer. We have to remove this. Okay. But many times when we do a type C radical hysterectomy, we also remove this part. So in nerve sparing, what is to be remembered is that you need to protect this part because this part is containing nerve fibers. So when you do your dissection and you stay above the deep uterine vein, okay, then automatically this posterior layer of the bladder pillar or the vesico-cervical ligament gets preserved, and that leads to nerve sparing radical hysterectomy. So there is one uterine artery and there are two uterine veins. One is superficial and one is deep. So ureter is running like this. The uterine artery is running over the ureter. So bridge over the water. You should remember that. Okay. The two uterine veins, of the two uterine veins, one is called superficial and deep. The relation is to ureter. So superficial uterine vein runs superior or above the ureter, whereas the deep uterine vein runs below the ureter. So it lies along the posterior aspect of the vesico-cervical ligament. So if you stay above the deep uterine ligament, automatically this layer gets preserved and you can preserve the inferior hypogastric plexus nerves which are running along this ligament. Okay, so that helps the nerve sparing. So coming to complications of radical hysterectomy, why are we doing all this exercise? Because radical hysterectomy is associated with certain complications. Obviously, the intraoperative complication can be damage to an organ, ureter, blood vessels, nerves. Okay. Post-operative complication, most common is UTI. The reason for UTI is that we have to keep the catheter for at least 10 to 14 days in a case of type 3 radical hysterectomy. Maybe shorter, 7 to 10 days in case of a type 2 radical hysterectomy. The reason for that is that when we do a conventional radical hysterectomy without preserving the nerves, the nerves which are supplying the bladder, they get damaged. So the bladder can become hypotonic. Okay, so if you remove the catheter immediately, the patient may not be able to pass urine. That is the reason why we put catheter in for a longer time. Okay, so because we put catheter for a longer time, obviously there are more chances of UTI, more chances of embolism. Besides this, there are certain later complications. For example, the development of fistulas, vesico-vaginal or uretrovaginal fistulas. So they are occurring in about 1 to 2% patients. Vesico-vaginal fistulas normally present by the 10th day. Okay, normally present by first week, 7 to 10 days, and patient can complain of continuous passage of urine. Okay, so when you examine the patient and you examine the wall, you can see some clear fluid coming out through the vaginal wall. Okay, and a crude way of knowing whether this is a fistula or not is to collect that fluid and send it for fluid creatinine. So if the fluid creatinine is high, so normally we do a serum creatinine side by side to compare the two samples. If the fluid creatinine is high, that is a indirect indication that you have a fistula somewhere. On the other hand, the uretrovaginal fistulas normally present late. They normally present by the end of second week, beginning of the third week. Okay. Reason for that is because these are devascularization injuries. So when we are dissecting the ureter, we have to be very careful. We have to preserve its mesentery as far as possible, and when we are dissecting the ureteric tunnel, we have to be sure that the lateral supply to the lateral ureter, the supply to the ureter is coming from the lateral side. So we have to preserve the blood supply from the lateral end when we are dissecting the terminal ureter. It is the terminal ureter which gets devascularized, and that leads to uretrovaginal fistulas. And one way of protecting it is to be good in your dissection procedure. Avoid too much of blunt dissection. Okay, preserve blood vessels as far as possible. Avoid using monopolar cautery in this area. If at all needed, you need a bipolar, or you use sharp cutting scissors and ligation. Okay, and preserve the lateral blood supply of the terminal ureter. So this uretrovaginal fistula normally presents at the end of second week, and patient generally complains that she is able to pass urine normally also, but at the same time she is passing urine involuntary. So she is having incontinence. Again, when we see the wart, you can see some clear fluid coming out of it. So whether it's a vesicovaginal fistula or a uretrovaginal fistula, how do you manage the patient? You send the patient for a CT IVU, okay, CT IV urography, and you need to ensure that the radiologist takes films which are delayed, number one, and number two, also takes film in prone position. Why we ask for films in the prone position and delayed films is because many times terminal ureter and the bladder, if the fistula is small, you may not be able to see it in early films. That is why we need the radiologist to take delayed films. We also need prone films because when a patient lies prone, okay, then basically the bladder gets filled faster, and the whole length of the terminal ureter, the bladder and the urethra can be seen much easily. Okay, so if let us say patient presents with incontinence, you've done a CT IVU, and patient has presented with a vesicovaginal fistula. So what is the management? I'm going to tell you for shortage of time. If the fistula is less than 3 millimeters in diameter on your CT IVU, then in those cases, these fistulas are very likely to respond to prolonged catheterization. So either which ways, you put in a wide bore catheter, at least an 18 to 20 French catheter, and keep it at least for 4 to 6 weeks. So many of the small vesicovaginal fistulas respond on their own, especially if they are less than 3 millimeter in size. Even if it is more than 3 millimeter in size, it is not advocated to do surgery right away. You catheterize the patient, you wait for at least 2 to 3 months. It is advisable to wait for 2 to 3 months because these are devascularization injuries, and it is likely that the fistula may enlarge over time. So whenever we do a surgical repair, it is preferable to wait for 2 to 3 months. And in the meantime, advise symptomatic care, genital hygiene, keeping the area clean and dry. Okay. Secondly, if it is a uretrovaginal fistula, these can be managed with ureteric stenting. Okay. So if possible, the urologist can be brought on board, and the urologist can do a cystoscopy and do a retrograde stenting, which is normally used. But many times what happens is, if there is a uretrovaginal fistula, there is a lot of surrounding edema. So it may not be possible to catheterize cystoscopically. In this case, we do a PCN of the involved site and then do an antegrade stenting from the PCN tube, and then later on remove the PCN tube. So this ureteric stent is kept for at least 6 weeks, and preferably for 2 to 3 months, but at least for 6 weeks, and then removed cystoscopically thereafter. Okay, and so this is basically the fistula part. The later complications, of course, like you said, are rectal bladder and sexual dysfunction, as well as lymphedema due to lymph node dissection. So in bladder complications, Yogesh, now the question is to you, what is more common, a hypertonic bladder or a hypotonic bladder?
Hypotonic bladder, ma'am.
Sorry?
Hypotonic bladder.
No, it is not. It is, we normally tend to think it is hypotonic. It is not. It is hypertonic bladder. So hypertonic bladder is more common after radical hysterectomy, wherein you are having involuntary spasms of the bladder. Okay, and that is leading to urge incontinence. So the treatment for this is basically medications like darifenacin. We normally give Daritin or darifenacin 7.5 milligram. To begin with, we can start once a day and then increase it to twice daily. And normally these resolve over a few weeks. The second, which is lesser common, is a hypotonic bladder. Okay, hypotonic bladder is more dangerous, not dangerous, but yeah, it is more problematic because many such patients may require prolonged catheterization. So initially, when the patient is hypotonic, we advise self-intermittent catheterization along with agents like bethenicol, which comes by the trade name of Urotone. Okay, so you advise bethenicol twice to thrice daily along with self-intermittent catheterization. But such patients, a few of these patients may require prolonged catheterization even lifelong. Okay, so this is basically it. Okay, now coming to pelvic exenteration, which you were talking about. So what are the indications of pelvic exenteration?
Pelvic exenteration usually preferred for central pelvic recurrences less than 3 centimeter.
No, size is not a criteria. Central pelvic recurrences, just say that. Don't add extra information. Yeah, central pelvic recurrences.
There is no evidence of distance metastasis. There is no evidence of lateral pelvic wall involvement, and there is long disease-free interval.
Very good, very good, very good, Yogesh. That is exactly the criteria. Okay, so it's a central disease, no extension to pelvic wall, no distant myths. Okay, and relative contraindications is the disease-free interval should not be less than 12 months, and preferably the patient should not have any paraortic or pelvic lymph node metastasis. So if all these criteria are met, pelvic exenteration, which involves the removal of the central disease along with the bladder plus minus the rectum, so it can be an anterior SOS total exenteration. It can increase the survival by 40 to 50%. However, if lymph nodes, if pelvic or paraortic lymph nodes are involved, then even with pelvic exenteration, the survival may not be 20 to 30%. So such patients are not ideal candidates for pelvic exenteration unless it is being done for a palliative setting. For instance, the patient has a fistula which is problematic and you just need to divert her because she's having local symptoms, then in those cases, explaining that this is completely a palliative procedure. So when you do for the anterior exenteration, normally we do an ileal conv. We are not doing continent pouches like Miami pouches. Okay, and we are doing normally such patients who require a complete resection of rectum like an APR. Okay, so they end up with 2 permanent stomas, one for the urine and the other for the stools. So basically these are central recurrences post radiation. Okay, so normally what happens is with radiation, all the tissues, there is a lot of radiation fibrosis. So as a result, most of the times you may not be able to find veins, and as a result, you may need to remove the complete rectum along with the anus and do a complete total pelvic exenteration. So what kind of flaps can you use after pelvic exenteration to avoid empty pelvis syndrome, pelvic cellulitis and pelvic abscesses? So these are common complications of pelvic exenteration because you've removed everything, there's an empty pelvis and it is likely to get infected, form an abscess or cellulitis. So what kind of flaps can you use to avoid that?
By laboratory.
You can use a gracilis flap or you can use rectus abdominis flaps like VRAM. Most of the times we are using VRAM. It is a myocutaneous flap, so it has its own muscle supply. It is easy to do. Okay. There are few authors who in trial settings are also using Bakri balloons, especially for exenterations in other organs, like say you're doing exenterations in a case of CA rectum, okay? Advanced CA rectum. So many times, yes, you can use a mental flap, Parth Shah, but it is not as effective. Most common is myocutaneous. Okay, gracilis and VRAM is most common. Okay, so yeah, that is pelvic exenteration. Now just give me some time to see what questions to ask you. Okay, what is trachelectomy?
Trachelectomy is a modality of fertility preservation in early cervical cancer, which involves removal of the cervix and paracolpos.
Okay, and then what do you do? Where is it used? Which females do you offer radical trachelectomy?
young age who have not completed family or desirous of fertility, we use this after excision of cervix and
Are there
endocervical
any
surgery has been.
eligibility criteria, or any young woman with a cervical growth can, you can offer
No,
radical
ma'am.
trachelectomy?
It is preferred for usually preferred for stage 1A 1A2, ma'am,
Yeah,
or
1A2 as well as 1B1 less than 2
less
centimeters,
2
okay,
centimeter,
with
ma'am.
no or limited endocervical involvement. So young females desirous of fertility with small tumors 1A2 and 1B1 less than 2 centimeters in size with no or very limited endocervical involvement. At least 1 to 2 centimeters of endocervix should be free. Reason for that is when you do a radical trachelectomy, obviously you need to take a tumor-free margin. So below you're taking the vagina. Above, you should have some amount of tumor margin, at least a 1 to 2 centimeter tumor margin for you to remove the tumor completely. So if the tumor is extending too much into the endocervical canal, you will not get any residual tumor free length. The length of the cervix is about 3 to 5 centimeters. Okay. So for it to be effective, for the surgery to be effective, it should have at least a 2 centimeter free margin. So if the endocervix is involved, you will not be able to achieve a complete tumor-free margin. So you remove the cervix along with parametra and the upper 2 centimeters of the vagina. Then the uterine stump is sutured with the vagina with interrupted sutures, and you also put a cerclage. You put a cerclage at the level of isthmus, which is being sutured to the vagina. The reason for that is the complications of radical trachelectomy. It can lead to cervical insufficiency, which can lead to second trimester losses. It can also cause cervical stenosis and infertility besides infection. So this is generally offered to young patients. In case the tumor is larger in size, more than 2 centimeters in size, and the patient is still desirous of maintaining her fertility and having her uterus for future possibility of pregnancy, such patients can be offered neoadjuvant chemotherapy after explaining that this is not the standard of care, okay, and if they have good response to NACT after 3 cycles, they can be offered radical trachelectomy. So about 70% of them do conceive and reach up to third trimester. Okay. So now let us say there is a patient who comes who went to a gynecologist for for discharge PV, and the gynecologist, without doing any biopsy beforehand, did a simple hysterectomy, and that simple hysterectomy is showing cancer. So how will you manage this patient? A patient has come to you. She's already had simple hysterectomy done outside by a surgeon or by a gynecologist that is showing Ca cervix. How will you manage this patient?
I look, I'd look, I'd look into the pathological reports. I'd look for parametry. The patient has undergone simple hysterectomy, so no parametry cannot be commented upon. But I'd also look for positive margins.
Okay.
And if there are any high risk features, then I would like to discuss in MDCT and plan for advanced CTRT.
Okay, so you need to divide, you need to see what kind of a tumor it is. So when a patient comes to you with such and such reports, okay, A, you examine the patient, B, you offer a imaging. Most commonly what we offer is a CT with contrast. Why are we not offering MRI in this patient?
Because of post surgery, inflammatory edema will be seen as invasion now.
No, so inflammatory edema can be seen in CT as well. See, it is not required. Okay, MRI is normally, it is required for assessing the tumor characteristics. Okay, once the surgery is already done, the uterus and the cervix is not there, and MRI will takes a longer time. So CT is sufficient. You do a CT scan of the whole abdomen and pelvis with IV and oral contrast and look for any lymph node involvement, any site of distant limits. Okay. If it is a microinvasive disease, by microinvasive disease I mean either 1A1 or 1A2 without LVSI. Okay. So normally it is possible to comment on LVSI on a simple hysterectomy specimen. Obviously it is not possible to comment on parametral invasion. If it is 1A2 with LVSI or 1B1, okay, such patients, you have two options. Okay, if a patient is young and is willing for surgery, okay, that patient can be offered radical parametrectomy along with the removal of pelvic lymph nodes. Okay, and then depending upon the final report, whether the factors are intermediate or high risk, can be offered radiation. But a saner way to go about it is that you see for the tumor characteristics. Okay, if the tumor size was already more than 4 centimeter, or there is deep cervical stromal invasion, factors which need radiation, then in those cases, even if you do a surgery and the patient will require radiation, it is preferable to send the patient to radiation upfront. So you need to see if it is a microinvasive disease 1A1 where the margins are free and there is no distant mets, you can keep the patient on close surveillance. 1A1 and 1A2 without LVSI. If it is 1A2 with LVSI, 1B1, 1B2, 2A1, okay, then in those cases, you look at the CT features. Are there any distant mets? Number one. Number two, you look at the pathology report. In the pathology report, are there any intermediate or high risk factors which necessitate the use of either radiation or chemoradiation? Okay. In case the tumor size was already more than 4 centimeter and plus the cervical stromal invasion is already more than half, even if you do a radical parametrectomy, this patient will require radiation. So it is not preferable to do a repeat surgery, a second surgery, and then give radiation. Such patients, it is preferable to operate these, send the patient upfront for chemoradiation. And obviously, in case the disease is already advanced and you feel there is no technical expertise to do a radical parametrectomy, it is of advantage to send the patient for adjuvant chemoradiation in any case. Okay, one question which I forgot to ask is, in your patient, let us say it was a 50-year-old lady, small tumor growth, 3 centimeters in size, involving the cervix, not involving any vaginal fornices. Okay, but on the MRI, it showed a lymph node, a pelvic lymph node, external iliac lymph node, which is 1.5 centimeters in size. So what will you do in this patient? This is an upfront case.
50-year lady with pelvic lymph node 1.5 centimeter. It is more likely to be metastasis to the lymph node. I'd like to do PET scan to evaluate the staging, and based upon that, we'll plan the further treatment.
So, no, so, okay, let me tell you the answer. No, let me tell you the answer. Let me first stop you there. Okay. Any enlarged pelvic node need not be positive. What are the CT criteria for this thing? CT or MRI criteria for an involved lymph node? A is short axis diameter more than 1 centimeter, but besides that, you have to look at other characteristics like presence of necrosis, loss of fatty hilum, presence of heterogeneous enhancement in case CT has been done, and also the involved lymph nodes are more likely to be rounded than elongated. Okay, so if a pelvic lymph node is 1.5 centimeter elongated, maintain fatty hilum, no necrosis, it can be reactive, especially in an Indian setting where PID is very common. Okay. So in such cases, it is not important to do a PET CT. There is a wrong conception amongst us that, PET CT gives us more information. No, not at all. In fact, PET CT, if anything, has more false positives than a good CT scan. Many times the slices of PET CT are thick and they may not give you more information. In fact, a thin slice CT may give you better information than a PET CT. There are high chances of false positives on PET CT. So an inflammatory node, which is due to a reactive process, can light up even on a PET CT. So a PET CT, an added PET CT will not give you any more advantage. In such cases, it is preferable to do an FNAC if you have the setting for an intervention radiology in your department. Do an FNAC. Tell the patient that the FNAC positive, only if it is positive, it is of value. If it is negative, it can be falsely negative. So in an FNAC, if the lymph node comes out to be positive, okay, then in such cases, it is preferable to send the patient for chemoradiation. Even though she is operable and you can remove the lymph node, you have to tell her that because this lymph node is already positive, that makes it stage 3C1 according to the new staging, and you will require chemoradiation. We want to avoid dual modality treatment, and upfront chemoradiation would be as effective with lesser side effects. If, however, the FNAC is negative, which it can be because FNAC can be falsely negative in many cases, then you have to explain the patient that I will take you up for surgery, but before proceeding with the radical hysterectomy, I will remove the lymph nodes, send them for frozen, and I will proceed with radical hysterectomy only if the lymph nodes are negative. You understand? Yogesh?
Yes, ma'am.
Yeah, okay. So, okay, now coming to adjuvant radiation, can you tell me what are the intermediate and high risk factors? And what do you give in
intermediate
intermediate risk factors, and what do you give as adjuvant therapy in high risk factors?
adjuvant therapy for intermediate factors consists of three factors. One is tumor size more than 4 centimeter, deep stromal invasion, as well as LVSI positivity. If
Yeah.
any one are present, then RT is preferred as an adjuvant modality.
No, not anyone. In intermediate, 2 out of 3 should be present. Okay?
Oh, yes, ma'am.
Presence of LVSI, presence of deep cervical stromal invasion, and tumor size more than
Tumor
4
size.
centimeter. For you to give adjuvant RT in a case of intermediate risk factor, at least 2 out of 3 should be present. In high risk factors, which is either the involvement of positive parametric or positive vaginal margins or positive pelvic lymph nodes. If either one is positive, then you give chemoradiation. Okay? Understood? So for intermediate, it is 2 out of 3. For high risk, it is any one. Okay. So, coming shortly to locally advanced Ca cervix. So, why are we offering chemoradiation in these patients and not just radiation? Is there any evidence to suggest that chemoradiation is better than radiation in locally advanced cervix?
In locally advanced cervix, it has in the Peters trial, GOG 109, it showed that the disease-free survival is comparatively better when adjuvant CTRT definitive CTRT is preferred.
So there were multiple trials which showed where we added any chemotherapy, okay, concurrent chemotherapy. Most of the time cisplatin was used. In some cases 5-fluorouracil was also used. It showed that it increased the disease-free survival as well as the overall survival. There was a big Cochrane meta-analysis by the name of Green. You should just remember this. So there were multiple randomized control trials. Then there was this Cochrane meta-analysis by Green, which said that when we used chemoradiation as compared to radiation in locally advanced Ca cervix, especially 2B and 3B, especially stage 2 and stage 3, the disease-free survival increased by 16% and the overall survival increased by 12%. And there was a marked reduction in the recurrence rates, both local as well as distant. That is why we now prefer concurrent chemoradiation over radiation in the treatment of locally advanced Ca cervix. So how do we give this treatment? We basically start with, how do we give this treatment? How is chemoradiation given, Yogesh, shortly?
Ma'am, it is given as first concurrent external beam RT with weekly cisplatin, followed by once the patient finishes the external beam RT, then it is followed by brachytherapy.
Very good. So EBRT is generally given in a dose of 45 to 50 gray in 25 to 28 fractions. Okay. And cisplatin is generally given in a dose of 40 milligram per meter square once weekly along with extended field, EBRT. Okay. And once this finishes, we give about 4 to 5 fractions of brachytherapy. So brachytherapy, you should know shortly that the older method was LDR, which is low dose rate, and now what we use nowadays is HDR or high dose rate. Why HDR was preferred over LDR was that LDR required the placement of uterine tandems and ovoids, and the patient needed to be hospitalized and stay in the same position for almost 2 days, for 48 hours. So it was given over 48 hours, either 1 or 2 applications, which was very cumbersome and it required hospitalization, and there was also increased chances of DVT because patient was immobilized for 2 days. So nowadays we give high HDR, which is high dose rate. Okay? So high dose rate is generally given about 6 grays per fraction, and it is given about 4 to 5 fractions after the completion of EBRT. And it can be given on an outpatient basis. The patient can go back the same day. Okay. And obviously it is more acceptable than an LDR. Although there are some trials which have shown that the recurrence rates with HDR are more than LDR, but you don't need to know that. So this is basically it. What is point A and point B?
Point A is taken as 2 centimeter above and lateral to the internal os or from the applicator, and point B is 3 centimeter lateral to the point A, about 2 centimeter above the cervical os.
So point A is not 2 centimeters above the internal os, 2 centimeter lateral to the internal os. Internal os is high up. So you take the central uterine line, okay, and you take the mucosal margin of the lateral vaginal fornix, okay. So point A lies 2 centimeters away from the uterine canal and 2 centimeters away from the mucosal membrane of the lateral vaginal fornix. That is point A, and point B is 3 centimeters lateral to point A. So what does point A correspond to and what does point B correspond to?
Point A corresponds to crossing of uterine artery, ureter with the uterine artery, and point B corresponds to obturator fossa.
Very good, very good. That's excellent. So basically point A and point B were basically used as markers to see how much brachytherapy, during brachytherapy, how much should a point A receive. Okay. So it was generally accepted that, in a case of locally advanced CA cervix, point A should receive at least a total of 80 gray. And a total of 80 gray, by that I mean both EBRT as well as brachytherapy. The total of it should be at least 80 gray in the treatment of locally advanced CA cervix. So what are the complications of radiation, acute and long term?
Acute complications, ma'am, bowel disturbances.
Yeah, so it can lead to diarrhea and it can lead to bladder disturbances like frequency. Later side effects are it can cause radiation cystitis, where the patient may present with frequency, urgency, incontinence, hematuria, and radiation proctitis, where the patient can present with bleeding per rectum. So patient can have radiation proctitis, a stricture or an ulcer, and patient can present with bleeding per rectum. And also the sexual disturbances because of vaginal dryness, vaginal adhesions, and vaginal stenosis, especially if the patient is not active after the completion of brachytherapy. And most of these radiation side effects, they occur in the first 3 years after completion of radiotherapy, but they can occur as long as up to 10 years. So the long-term effects of radiation are more. So what is IMRT?
That is image modulated delivery of radiation therapy modulated by imaging.
Modulated by images, right? So you do a CT planning, do a CT planning before giving each radiation every day, so as to adjust for this organ movement each day, in order to decrease the side effects. So this is generally preferred when we are giving extended field RT to the para-aortic chain, because we need to really preserve the organs, especially the small bowel, because it can cause RT enteritis, number one. And secondly, it is also preferred after hysterectomy. After hysterectomy, if you are giving radiation to a patient, where again we know that the bowel is all coming in the plane where uterus was, then in those cases, we prefer IMRT. Third, where it is preferred is when we are giving re-radiation. Suppose a patient received chemoradiation up front and now has a disease recurrence which is local. Okay, either that patient can go for pelvic exenteration if it is a central recurrence, or if the disease is advanced and the patient is not amenable to exenteration or not accepting pelvic exenteration, then a few percentage of these patients can be re-radiated. Okay, at least the disease-free interval should be at least 2 years before re-radiating the patient. So where in cases where we are doing re-radiation, there we prefer IMRT. Okay. So what is extended field RT and where do you give extended field RT?
Extended field RT is involving of the field para-aortic region, ma'am. This is given in cases of suspected para-aortic lymph nodes.
Okay. So so extended field RT is generally given when you have involvement of para-aortic lymph nodes on a PET scan. There is something known as surgical staging to assess the para-aortic lymph node disease. Okay. So where in trial settings, in locally advanced CA cervix, they are removing the para-aortic lymph node chain either laparoscopically or robotically to assess for microscopic disease in the para-aortic chain. The theory behind it is that PET scan can miss up to 20% microscopic disease in the para-aortic chain, which can be picked up by the staging, wherein para-aortic lymph node staging, which is done laparoscopically in advanced CA cervix. But this is not a part of standard guidelines. This is not something which we do in clinical practice. It is only being done in trial settings. As of now, it has not shown to improve the survival outcomes over and above doing a PET scan and directing your radiation as per the PET scan. So it is not a part of clinical practice. It is only done in clinical settings. So cases where you give extended field RT is A, where the para-aortic lymph nodes are involved, number one. Number two, where common iliac lymph nodes are involved. Third, where you have very bulky pelvic nodal disease or both bilateral pelvic lymph nodes are involved. There, in those cases, we give extended field RD. Okay. Say you have treated a patient of locally advanced Ca cervix with chemoradiation. Okay. That treatment finishes today. Her last brachytherapy was today. After how long will you assess after how long will you assess whether there is response to radiation? Will you assess it now or will you assess it later?
Ma'am, usually assessed at a later date, preferably after 6 weeks, ma'am.
Yeah, why is that?
Ma'am, because radiation is associated with long-term effect of radiation, ma'am.
Yeah, so it has long killing time because basically it's a long-term kill. So many times you may find some amount of residual tissue just at the finishing of brachytherapy, but if you assess it after 6 weeks, the disease is gone. So normally after 6 weeks, the radiation oncologist calls the patient and sees for for any residual disease. Okay, in case the residual disease is suspected, then in those cases they generally advise a PET scan in this setting. Okay, and take a biopsy from the tissue. Okay, so if after radiation there is some amount of residual tissue left and on PET scan there is no any other distant mets, everything has been taken care of, but there is a small amount of residual tissue left behind on the cervix after radiation, what can you do?
Ma'am, in that case, we can repeat PET CT after 6 weeks, or we can 3 months, or we can repeat CCT at 2 months, ma'am. To look for whether
it is not about what you do when. So yes, you are right in that sense that we don't like to offer her treatment right away. We would like to wait for at least 2 to 3 months after finishing of the surgery and assess her again clinically. That is showing disease. Let us say you assess her at 3 months, that is showing central disease, some residual disease on the cervix. How will you treat the patient? You have done a CT/PET CT and that shows no disease elsewhere. How else now what will you do?
If there is no residual disease at or repeated scan, then
कितनी बार scan करोगे बेटा? You've done the scan. There is residual disease on the cervix, which is proven by biopsy. How will you manage this patient? So, is there any role of adjuvant hysterectomy post-radiation therapy? This is something known as AHPRT. Okay, so basically, if there is small amount of residual disease left behind after the finishing of radiation, that is EBRT plus brachytherapy, and it is a small amount of small central disease, such patients can be offered surgery in the form of type 1 hysterectomy, type 1 or type 2 hysterectomy to just remove that disease. Okay, lymph nodes have already been taken care of by radiation and it is a small central disease. This few percentage of patients who have residual disease, which are less than 5%, after the finishing of radiation can be offered adjuvant hysterectomy. Okay. Now just let me see what else is left. Just give me some time. I will come to pre-invasive disease, don't worry, we will discuss that shortly. Okay, what is the survival rates? Yogesh, in the meantime, can you tell me the survival rates of all stages of the disease? All of you should please know the cervical staging, both 2009 as well as the latest cervical staging. Okay, I'm not discussing it here because that will take long, but you should know what the differences are. Okay, so, yeah, tell me, what are the survival rates? 1, 2, 3, 4. What are the survival rates?
Survival rate for early stage, early cervical cancer 1B and 2A, it has been found that it is survival rate of almost 80%.
Okay, go on. First you tell me, then I'll correct you. Bolo beta. Okay, so stage 1A1 microinvasive disease basically has survival more than 95%. Stage 1B1 has a survival of 90%. 1B2, 2A1 have a survival of 75%. About 2B has 65%. Stage 3 has a survival of roughly 40%. And stage 4A to 4B have a survival of 15 to 20%. Okay. So you need to know this. These are important figures which you need to know. Okay. Last question before we go to pre-invasive disease and cervical cancer screening is, how do you manage cervical cancer during pregnancy? Yogesh, do you have any idea? Let us say a woman is pregnant and presents with cervical cancer during pregnancy. How do you manage this patient? Okay. So basically the management during pregnancy is divided into two parts. whether the pregnancy is less than 20 weeks or more than 20 weeks. Okay, if the pregnancy is less than 20 weeks, it is preferable to sacrifice the pregnancy and treat the disease. Okay, so if the disease is upfront operable, then you can go for an upfront radical hysterectomy with the fetus in situ and remove the disease along with the fetus. Okay. If it is not upfront operable, you can offer this patient chemoradiation. Patient need not undergo medical termination of pregnancy prior to initiation of radiation, because once the radiation starts, there is spontaneous abortion and expulsion of the fetus. Okay. If the pregnancy is more than 20 weeks, it is preferable to continue the pregnancy into third trimester till the lung maturity. Okay. So we continue the pregnancy till the lung maturity. If it is a stage 1 disease and upfront operable, then we take the patient, such patients, any patient with cervical cancer who is pregnant has to deliver by a cesarean section. There is no role of vaginal delivery. If you do a vaginal delivery, this disease is likely to spread. Okay, so all these patients have to be taken up for a C-section, and that too a classical upper segment C-section and not a lower uterine segment, so as not to disturb the cervix. Okay. So if a patient is more than 20 weeks and the baby has progressed to lung maturity, then you can take the patient up for surgery, do a cesarean section, deliver the baby, and then do the radical hysterectomy in the same sitting. Okay, provided she is operable. If the pregnancy is more than 20 weeks but the disease is locally advanced, then you continue pregnancy till fetal lung maturity, deliver the baby by C-section, and 3 weeks after C-section you give chemoradiation. Okay. In case a pregnancy is less than 20 weeks, okay, and the patient is not willing for termination of pregnancy, such patients can be offered neoadjuvant chemotherapy, explaining that this is not the standard of care. This chemotherapy is safe during pregnancy, during second and third trimester. So we give the same paclitaxel and carboplatin, and such patients can be taken on to the third trimester till lung maturity and then delivered via C-section. Okay. So, shortly, where all do we use chemotherapy in Ca cervix? In what settings? So, one is the concurrent setting during chemoradiation, number one. Second is neoadjuvant. So, neoadjuvant has not become a part of standard practice. There were many clinical trials to show, earlier there were some trials which had shown some response with neoadjuvant chemotherapy in locally advanced Ca cervix. So I was part of one trial actually, of the Tata trial, the NACT cervix trial. So wherein what we did was locally advanced Ca cervix, they were divided into two arms. One received chemoradiation, the other received chemotherapy, systemic chemotherapy. So if a disease was locally advanced, and by locally advanced I mean 1B2, 2A1 and 2A2 and 2B. Okay. So these patients, the NACT arm first received 3 cycles of chemotherapy. If with 3 cycles of chemotherapy the disease regressed and became operable, such patients then underwent open radical hysterectomy. And after open radical hysterectomy, depending upon the final HBR, they received or did not receive adjuvant radiation, whereas the standard arm received standard chemoradiation. So it was found that the chemoradiation arm had better survival rates. Both the disease-free survival and the overall survival was better in the standard arm. Okay? And the side effects were more in the arm which received neoadjuvant chemotherapy. The reason for that was that they received chemo, then they underwent hysterectomy, and about 1/3 of them also received adjuvant chemoradiation. So it was a tri-modality treatment. So the complication rate, the side effects, they were much more common in the NACT arm. So it has not shown to be of any advantage, and as of now the treatment of choice in locally advanced Ca cervix is chemoradiation. The same results were also published by the recently published EORTC trial. That also showed similar outcomes like our Tata trial. So again, chemoradiation is the standard of care. The third case where radiation chemotherapy is used is either in pregnancy or in cases of radical trachelectomy, patients where the disease is more than 2 centimeters and they are keen on fertility sparing. And the last is in a case of recurrence, okay, where there is distant recurrence or there is disseminated disease and you need to take the patient up for systemic chemotherapy. Okay, fine. Now coming to the screening. Can you tell me what the screening is? How do we do screening? What are the methods used and from what age do we start screening?
Screening is usually preferred from age 21. From age 21 to 29, a 3-yearly pap smear is done. And post 30 years, either we can do pap smear with HPV DNA testing once in a 5 year till the age of 65 years, and if the screening can be stopped at the age of 65 years if previous three screenings were negative. Uh, Either or it can be done with from age 30 from age 30 years. If there is positive for HPV, then reflex HPV DNA testing has to be done.
No, you don't need to add that. You were right before. So, yes, as per universal guidelines, it is starting at 21. The FOGSI guidelines for India are starting it at 25. Okay. So, you are right. 21 to 30, it is 3-yearly pap smear. The reason why we do not do HPV DNA in this population is because HPV DNA is very common in this population. This is a sexually active group, and more than 95% of these patients can turn out to be HPV DNA positive. So, as a result, that leads to unnecessary colposcopies. So this age group, we do not prefer to do HPV DNA. Between 30 to 65, we do either a co-test, HPV DNA and pap smear, or a 3-yearly pap smear. Or now, according to the newer guidelines, you can just do an HPV DNA, and that is showing equal higher sensitivity. So the sensitivity of a single pap smear, of a conventional pap smear, is 60%. Okay, if you do pap smear successively, that is, you do it once, twice, thrice, then the sensitivity increases to 90%. But for a single pap smear, the sensitivity is only 50 to 60%. Unlike an HPV DNA hybrid capture, where the sensitivity is as high as 95%. The specificity of a pap smear is good. A conventional pap smear has a specificity of 95%. HPV DNA has a slightly lower specificity of 93%. Okay. So, So what are the advantages of liquid-based cytology?
Ma'am, reflex co-testing can be done with liquid cytology, which is not possible with smear-based pap smear.
Yes, that is one advantage. What is the second advantage?
Reflex co-testing can be done, ma'am.
And that you've done, no? You've done. So basically, you get on a conventional smear, you get many unsatisfactory smears, either because the smear is too thin, there are too few cells, or the smear is too thick, or there is a lot of inflammatory cells or blood or inflammatory exudate, which precludes the examination of a conventional smear. So that is why what is happening in a liquid-based cytology is you are smearing it onto a cytobrush. That cytobrush then undergoes a spin cycle, and those cells are extracted. So the number of unsatisfactory smears is significantly reduced, number one. And number two is that yes, it can be tested for HPV DNA along with also media and gonorrhea. Okay, so HPV DNA can be done in the same setting. So that is the advantage. Okay. So, you have already mentioned when you stop testing. If a patient has had a hysterectomy, do you continue with the pap smear or the HPV screening?
Yes, ma'am. For lower, to rule out the possibility of lower uterine segment lesions, pap smear.
Sorry, come again. Just repeat it. What did you say?
There is a high possibility of lower segment cancer. So HPV has to be testing has to be.
So no, that is not correct. So normally we continue with after hysterectomy, after a simple hysterectomy, where this thing is done. Your hysterectomy has been done for a benign indication. Then in those cases, it is not required to do pap smear screening. In case where the hysterectomy has been done for CIN2, CIN3, then in those cases we have to continue pap smear screening or wall screening for additional 20 years. Even if the universal guidelines say that, you stop it at 65 years. So say a female of 60 years underwent a hysterectomy and the final histopath was CIN2/CIN3. Okay. So in those cases, you will not stop screening her. You will not stop screening her at 65. You will continue the screening for 20 years at least. Okay. So, okay, all right. So, when do you do a colposcopy? What are the indications of a colposcopy? What is a transformation zone? First of all, tell me what a transformation zone is.
What do you want?
What is a transformation zone?
That is transformation zone is transition zone from endocervical to ectocervical region, ma'am. That is transition from glandular tissue.
No, Yogesh, that is not correct. No, no, Yogesh, that is not correct. It is not the region between endocervical and exocervical. It is basically the original squamocolumnar junction. So the exocervix has a squamous epithelium. The endocervix has a columnar epithelium. So originally what happens is there is a original squamocolumnar junction which is there. Okay. Thereafter, when the during puberty or during pregnancy, during puberty, there is basically release of hormones. As a result of release of hormones, the endocervix everts. When the endocervix everts, there is basically the endocervix, a part of the endocervix is exposed to the vaginal microflora, that is the lactobacilli, and there these cells undergo metaplasia from columnar cells to the squamous cells. So now there is formation of a new squamocolumnar junction. So the transformation zone is between the original squamocolumnar junction and the new squamocolumnar junction. The region between these two junctions, that is known as transformation zone. And the reason why it is important is because all the pre-invasive lesions of the cervix as well as Ca cervix, most of these, they occur in the transformation zone. And it is this zone that we need to target when we are doing, say, a leap or a cone biopsy. So now coming to colposcopy. What are the indications of colposcopy?
Colposcopy done when pap smear is indistinct and the cervical transformation zone is not seen.
You're talking about you're talking about cone biopsy. What are the indications of this thing, colposcopy? So colposcopy is done when either, you get a report of ascus where the HPV DNA is positive, number one. Secondly, if there is an abnormal looking cervix, patient is having complaints of persistent discharge, postmenopausal or postcoital bleeding. Thirdly, there is persistent L-cell, okay, CIN1 or CIN2 on cytology, or there is presence of H-cell, which is CIN3, okay. So you need to understand that as of now, L-cell, H-cell, these are the terms which are used for cytology parameters, whereas CIN1, 2, 3 are terms which are used for biopsy parameters. So when we do a pap smear, we may get a report of normal, NILM. We may get a report of ascus, which is atypical squamous cells of undetermined significance, or we may get low grade or high grade squamous intraepithelial lesions. Okay, so these are cytological diagnosis. When we do a biopsy, some of them may come out to be CIN1, 2 or 3. Okay, so colposcopy is done in these cases. In ascus, if we get a report of ascus, normally there is a triage. Either you can keep the patient under observation and repeat your cytology after 1 year, or you can do an HPV DNA. If high risk HPV DNA is positive, you can go for colposcopy. So that is one indication. Second is abnormal looking cervix, persistent discharge, persistent postcoital bleeding, or there is L-cell, persistent L-cell on cytology, or we get an H-cell. Or if we are getting an H-cell on pap smear, then in those cases we need to do a colposcopy. So colposcopy basically you have to look at aceto-whitening, Lugol's iodine staining, as well as the vascular patterns. So briefly, acetic acid, what we use is 3 to 5%. In order to prepare 5% acetic acid, we don't get acetic acid as a prepared formulation. It is prepared fresh. We get concentrated acetic acid. So in order to prepare 5% acetic acid, we take the concentrated acetic acid, about 19 ml, and to that we add, we take 1 ml of the concentrated acetic acid and we add 19 ml of sterile water to prepare 5% acetic acid. Lugol's iodine comes as a prepared solution. So initially when you do a colposcopy, you see grossly what are the, is there any abnormality on the cervix. Then you use something known as a green filter in order to see the vascular patterns. So abnormal vascular patterns can be punctations, coarse, it can be mosaicism, or it can be abnormal branching. Okay. Thereafter you apply aceto-white, thereafter you apply acetic acid. Acetic acid basically coagulates all the proteins. So any abnormal proteins which are there in the cervix will then appear as coagulated dense aceto-white. So any area which is dense aceto-white demands biopsy. Okay, and after keeping the acetic acid for about 2 to 3 minutes, we then apply Lugol's iodine. Normally, the vaginal mucosa produces glycogen. So as a result of lactobacillus, so glycogen stains brown with Lugol's iodine. In case it is not staining brown, okay, it is mustard yellow, cervix, exocervix or vagina, that part is abnormal and that also demands a biopsy. So this is basically what you need to know about colposcopy. There are various scores like Reed's colposcopic score. Normally, we are not using them routinely. We are going by our clinical parameters. Okay. What are the indications of cone biopsy?
Cone biopsy usually preferred for stage 1A lesion with no lymphovascular invasion suspected.
So no. So you have to say one is a diagnostic indication, the other is a therapeutic indication.
Okay.
You are coming straight to the therapeutic indication. Okay. So cone biopsy is done when the colposcopy is inadequate. Number one. Colposcopy can be inadequate because of non-visualization of the whole transformation zone. Normally, there are three types of transformation zone. Type 1 transformation zone is where you can see the original and the new squamocolumnar junction completely. Type 2 is where the new squamocolumnar junction is retracting inside, but with the help of an endocervical forceps, you can open it up and then see. And type 3 transformation zone is it has receded so far inside that you cannot see even after retracting with an endocervical forceps. So, A, when the colposcopy is inadequate. Secondly, when you have done an endocervical curettage. Whenever you do a colposcopy and take a cervical biopsy, you should always do an endocervical curettage because many times the lesion may not be there on the exocervix, it may lie inside the endocervix. So whenever you're doing a colposcopy and doing a colposcopic targeted biopsy, you should always do an endocervical curettage. So cone biopsy, besides inadequate colposcopy, the second indication is a positive endocervical curettage. Okay. Third is that there is a discrepancy between your cytology and your biopsy findings. Fourth is when you want to rule out any microinvasive cancer. So, for instance, you get a report of say HCL, okay, and you have done a colposcopic directed biopsy. That colposcopic directed biopsy shows that it is CIN3, okay. So, will you proceed to surgery straight away? So, the treatment for CIN3 is what type of hysterectomy, Yogesh? If it was a CIN3 lesion, not an invasive lesion, if it was CIN3, what type of hysterectomy will you do?
Simple type 1 hysterectomy.
Yes, type 1 hysterectomy, correct. So, but unfortunately what happens is, if you just take a targeted colposcopic biopsy, about 25% of CIN3 can harbor a microinvasive cancer. So, whenever we get a diagnosis of CIN3, it is preferable to do a cone biopsy or a leap, okay, in order to rule out microinvasive cancer because 25% of these patients may harbor microinvasive disease. And then your treatment plan will change. If it is a 1A2 type of microinvasive cancer or 1A1 with LVSI, then in those cases, simple hysterectomy will not be enough. You will have to do a type 2 radical hysterectomy with a lymph node dissection. So it is important to rule out microinvasive cancer in a case of CIN3 before proceeding to simple hysterectomy. Otherwise, your treatment will be inadequate. So many times, in fact, when on cytology, that means on pap smear, if we are getting a report of HCL plus minus the presence of HPV, directly go for leap or cone biopsy as a see and treat kind of. That is, do a leap or a cone biopsy, you remove that complete transformation zone. So cone biopsy or leap involves the removal of complete transformation zone. But in a cone biopsy, we also take a part of the endocervical canal and it is generally done by cold knife. Okay. Unlike a leap, which is more superficial, and also has thermal artifacts at the periphery because it is using high voltage current. Okay. So cone biopsy in HCL, in cases where your pap smear is showing HCL, many times it is preferable to go for a cone biopsy or a leap straight away so as to remove the complete transformation zone. It will tell you the diagnosis. It will tell you whether there is microinvasive cancer or not, number one. Number two, it can also serve as a therapeutic option in patients who require fertility preservation, provided two things. So, cone biopsy can serve as a therapeutic approach to patients with microinvasive cancer, that is 1A1 and 1A2 without LVSI, provided the margins of the cone biopsy are negative, number one. Number two, endocervical curettage is also negative. If either of these two is positive, either the margins are positive or the ECC is positive, then you have to repeat a cone biopsy. Okay. And in case the patient is not desirous of fertility and a cone biopsy cannot be repeated, then you go for a type 2 radical. Okay. So that is basically it. Briefly, I think last would be HPV vaccines. Can you tell me a bit about HPV vaccines?
There are three types of vaccines available. One is Cervix, which is a bivalent vaccine, and Gardasil, that is a tetravalent vaccine, and there is Gardasil 9, that is monovalent vaccine. usually recommended from 11 to 12 years of age, but can be continued up to 26 years of age.
Okay. So yeah, you are right. So between the bivalent and the quadrivalent, the recommended age is 11 to 13 years. It can be given up to 26 years. The FDA has also approved it to women up to 45 years of age. But with the understanding that these vaccines are prophylactic vaccines, they are not therapeutic vaccines. So basically the idea is to prevent HPV infection. If the patient is already HPV infected, it will not treat that infection. So it is not a therapeutic vaccine, it is a prophylactic vaccine. At the same time, it is not necessary to do an HPV test to take patients up for HPV vaccine. So it does not mean, say, a 21-year-old who's active and she comes to you, okay, doctor, I want an HPV vaccine. So you don't need to ask her about her HPV status. No, neither do you need to do an HPV test to confirm whether she's HPV positive or not. These women can be given HPV vaccine, okay, telling them that it will not treat the current infection but will prevent it from further reinfections, okay. So you need to understand that these vaccines are covering what type of high risk subtypes are they covering, Yogesh?
Cervix covers HPV 16 and 18. Gardasil covers 6, 11, 16, 18. And Gardasil 9 cover along with Gardasil 4, 31, 33, 45, 52 and 58 mark.
Okay. So basically the high risk ones are HPV 16 and 18. 6 and 11 are responsible for formation of genital warts. Gardasil 9 has been recently introduced, and recently we've also had the Indian vaccine released by the Serum Institute of India, Pune. Okay. So basically 16 and 18 cover only 70% of the cervical cancers. The patients need to understand that it is a prophylactic vaccine, number one. Number two, the efficacy of this vaccine is maximum when it is given in adolescent girls prior to the onset of sexual activity. In young girls, the efficacy rate as reported by the Patricia trials and all, it is about 95 to 98%. When the woman is already active, then the efficacy drops to about 40 to 45%. Okay. Third, they need to be told that in spite of receiving the vaccine, 30% of the cancers are not covered by the quadrivalent vaccines, and these women, as of now, need to undergo the same screening as a non-vaccinated woman. So, just giving vaccine does not mean that the patient should not be undergoing cervical cancer screening. As of now, the guidelines for cervical cancer screening are exactly the same in the vaccinated and unvaccinated women. Now, according to the ACOG, which is the American College of Obs and Gynae, the recommendation below 15 years, it is said that only 2 doses of vaccine are enough. So both Cervarix and Gardasil, we need to give 3 doses. Cervarix is given as 0, 1 and 6. But Cervarix is now on its way out. It is very difficult to find Cervarix nowadays. What we are getting now more common is Gardasil. So Gardasil, the dosage is 0, 2 months and 6 months. Okay. Below 15 years of age, it is recommended that only 2 doses are enough, 0 and 6. Above 15 years of age, you require 3 doses, 0, 2 and 6. The Indian guidelines are slightly different. They have shown that even in girls up to the 18 years of age, 2 doses are enough. Okay. So 0 and 6 is acceptable below 18, and above 18, 3 doses. Although you don't need to learn this, but there are recent trials which have shown that even 1 dose of vaccine may be enough. But you don't confuse yourself. For you, it is 15 years. The universal guidelines is 15 years. But in India, they have shown that even below 18 years, 2 doses may be enough. Okay. Now you come to your questions. Yogesh, I will ask you to read the chat box and tell me what the queries are. Okay, I'm getting repeated calls from the hospital, so I need to attend those as well. Can you please start with the chat box, Yogesh, that I'm giving that task?
Yes,
Please read the chat box and tell me what the queries are.
1B2 lesions, that was regarding the,
you need to be a little louder.
For MRI.
You need to be a little louder.
There was a question. There was a question for MRI findings of invasion. That is when you are going to do MRI, that is for more than 1B2 lesion or gross invasion and biopsy. Role of NACT or NART followed by surgery.
NACT we have already told you. Right now there
Follow.
is no role. It was done only in
Yes.
trial settings, and that did not show any survival advantages. Rather, the survival outcomes with concurrent chemoradiation were better with lesser side effects.
Ma'am, do we do HPV DNA testing every 6 monthly while on follow-up for fertility sparing protocol?
So, fertility sparing protocol, if you've done a radical hysterectomy, if you've done a radical trachelectomy, yes, you should be following up with pap smear and you can add HPV DNA. There are no standard guidelines to what you should do when you have done a radical trachelectomy, but yes, you should be following up this patient every 6 monthly. Definitely with cytology, but you can add HPV DNA to it, and some patients may also require a colposcopy. That's a good question, actually.
What is the logic behind both superficial and deep injection while doing sentinel lymph node biopsy?
Okay, so you need to understand that the sentinel lymph node biopsy is not recommended as part of universal guidelines for cervix. There are trials like Senticol trials which have shown good sensitivity of 92% and a false negative rate of about 8%. But as of now, sentinel lymph node is not incorporated for management of CA cervix. It is only incorporated for the management of CA endometrium and selected cases of CA vulva. So please do not give this answer in cervix. As of now, it is part of trial setting. It is not this thing. But coming to your question, the lymphatics are superficial and deep. That is why the injection is also, given in the same way. First superficially and deep, so that all the lymphatics are covered, and then they move from the cervical and the paracervical region to the obturator fossa, external iliac, internal iliac, and then high up into the presacral and the paraortic group. That is the this thing.
What is the exact reason to prescribe a specific dose to point A and B?
So this was an older protocol. This point A and point B were defined when we used to give LDR brachytherapy. Okay, it is not so much relevant now, but because these are, you get old examiners, this is an old question, and it for giving these specific points is so that there is a uniform dosage, there is a universal guideline that this point should receive this amount of radiation, so as to conform to the brachytherapy conformation, which should be around, which should be pear shaped, and that the region which is harboring cancer cells should receive adequate radiation. So this standard dose was given that about 80. It is not fixed that it has to be 80. It can be modulated. You can increase it to 95 depending upon how far the disease is going. So if it was a stage 2B or a 3B disease, you would give higher dose to 0.2. Okay. So it is not a fixed dose, but these dose parameters are given so as to maintain a standard guideline that this particular point is receiving such particular amount of radiation, because that radiation, at least that amount, is needed to sterilize the tumor tissue.
Management of 1B3 and 2A2 tumors in young female.
Yeah, so we've already discussed that. The new 1B3 is basically the old 1B2. So in young patients, we have already discussed. We first do an MRI. First of all, we clinically see what the disease is, okay? And if only the vaginal fornix is involved, if the patient is young, we do an MRI pelvis with contrast, MRI whole abdomen pelvis with contrast. In the MRI, we look for the tumor size. Besides that, we look for the cervical stromal invasion. If the cervical stromal invasion is less than half, these patients can be offered surgery. If the cervical stromal invasion is more than half, then the patient should be told that there is a very high chance that she will require radiation, because already you have two intermediate risk factors, and counseled that chemotherapy, chemoradiation will be of more advantage, because then that will avoid a dual modality treatment. So do an MRI. If the cervical stromal invasion is less than half, go for surgery. If cervical stromal invasion is more than half, counsel the patient that she already has two intermediate risk factors and will require radiation even after surgery. Okay.
For HIV positive patient, what is the screening schedule?
The screening schedule for HIV patients is actually the same. Only thing is that they are likely to harbor more pre-invasive and invasive lesions. The HPV infections are less likely to regress. So in case you are finding, some abnormality on pap smear, it is better to consider LEAP in such patients rather than going for a colposcopic directed biopsy, because they are more likely to harbor pre-invasive and invasive lesions as compared to normal population due to immunosuppression.
Is there any role for staging laparoscopy, ma'am?
Staging laparoscopy for, so that is what I was saying. The laparoscopic para-aortic lymph node staging is there, but that is only in clinical trial settings. It has not been incorporated as part of clinical practice or universal guidelines. It has been done in clinical trials to remove the para-aortic lymph nodes, in locally advanced Ca cervix in order to determine and detect microscopic disease in the para-aortic lymph nodes, because in case microscopic disease is detected, then your field of radiation will change from just pelvic to an extended field RT. But they found that it did not really improve the survival outcomes. It did not provide more advantage over and above PET CT in a clinical scenario. So as of now, it is only a part of trial. It has not changed our universal guidelines in any way. So we are not doing it as part of any standard practice right now.
What is the management of residual disease after chemo RT in pelvic lymph node?
Yeah, we have discussed that. Adjuvant hysterectomy. Yes,
oh, ma'am, that question was residual disease after chemo RT in pelvic lymph nodes, ma'am.
Okay, so if there is, so fine. So if there is residual disease in the pelvic lymph node basin after radiation, so you need to assess. You need to do a proper CT, and you need to assess. These patients may also require CT angiography to assess their involvement along with the pelvic blood vessels. Okay, so such patients need to be counseled. You can give a trial of chemotherapy, but practically speaking, chemotherapy in a field which has already received radiation, the chemotherapy doesn't work well. Some patients can be offered what we call as type D type of radical hysterectomy, which is LEAR, laterally extended endopelvic resection, which is removal of the paracervix along to the lateral wall, along with the removal of hypogastric vessels. So after radiation, it is more likely that these lymph nodes may be there is a lot of desmoplasia and they are involving the pelvic blood wall vessels. So in order to remove them, many times you may need to remove the vessels as well. So you need to bring a vascular surgeon on board, and such patients, after doing proper CT angiography, after consultation with a vascular surgeon and consultation with the patient as well as the attendant, that it is a morbid procedure, these patients can be offered LEAR, laterally extended endopelvic resection. But that's a very small subset.
Pap smear post-hysterectomy, post-adjuvant RT when to start for follow-up as post-RT false positive results?
No, so that's a good question. We did not discuss the follow-up. The follow-up is exactly the same what you do in this thing. You do a clinical examination. In patients who have undergone hysterectomy, you do pap smears at every visit. So that is every 3 monthly, the first 2 years, then every 6 monthly, then after 5 years, once in a year. So on every follow-up, you will do a pap smear for a patient who has undergone radical hysterectomy. For a patient who has received adjuvant radiation, or for a patient who has received radical chemoradiation upfront, pap smear is not advisable because radiation leads to a lot of changes in the vaginal mucosa. There may be some changes which can appear as dysplastic and cause false positivity on pap smears. So normally after radiation, we are not recommending the use of pap smears, nor are we doing it in clinical practice.
Management of 1B lesion in elderly unfit patient for surgery.
What do you think? Yogesh, you answer that question. It's a very straightforward question.
RT, ma'am.
Yeah, radiation. If a patient cannot withstand chemotherapy, that is okay. Radiation is quite effective.
Yes,
okay. What else?
That's all, ma'am.
Okay, yeah.
These are the questions, ma'am.
Yeah. Anything else? Okay, I think it was a long class.
Thank you so much, ma'am.
Yeah, okay. So in case you have any doubts, I think Vartika has my number. You can communicate through her, or we can have some platform wherein you can ask me some questions and I can give you the answers. Okay. So thank you very much, and I hope this has helped you. Vartika had asked me about a class on CA endometrium. So unfortunately, I'm traveling the next week. It will not be possible for me to take a class on CA endometrium next week. What I do have is I have an international webinar on 27th of October. That is on the role of lymphadenectomy. So I will pass on that Zoom link to you guys. So I think it will be very helpful if you attend that, because that will answer a lot of questions of lymphadenectomy, because a lot of lymphadenectomy what we are doing is in CA endometrium. And you can in general be asked about lymphadenectomy in gynae onco cancer. So that should help you. For people who are having their exams slightly later, that is mid-November, we can keep a class on CA endometrium. Not next week, maybe after 6th or after 6th November. Okay. For people who are having their exams earlier, I think you can just attend that seminar. I think that should help you a lot. I will give you the link, and in case you have doubts after that, we can discuss it, or we can have a short class in between. I will try. Okay. Thank you so much. Thank you, guys. Bye bye.